Welcome to another episode from the Veterinary Medicine Digest. Today, we are embarking on a truly deep dive into one of the most complex and occasionally devastating conditions we manage in small animal specialty practice, the intersection of hepatic dysfunction and central nervous system pathology. We will be focusing specifically on hepatic encephalopathy and the vascular anomalies that frequently drive it, such as congenital portosystemic shunts. Our goal today is to bridge the gap between traditional clinical assessment and the emerging role of advanced neurophysiological monitoring. We will spend a significant amount of time discussing a groundbreaking new study regarding the perioperative assessment of electroencephalography in dogs with these vascular anomalies. But before we get to that primary piece of research, we need to lay a very solid foundation.
That is exactly right. To understand where we are going with neurophysiological biomarkers, we have to understand the sheer complexity of hepatic encephalopathy itself. It is not a single disease entity, but rather a spectrum of neuropsychiatric abnormalities that arise in the face of liver dysfunction once we have excluded other primary intracranial diseases. Traditionally, we have categorized this in humans and animals into three distinct types. Type A is associated with acute liver failure. Type B occurs due to portosystemic bypassing without intrinsic hepatocellular disease, which is where most of our congenital shunt patients fall. Finally, Type C is associated with cirrhosis and portal hypertension. While the clinical signs are well documented, ranging from subtle lethargy and tielism to head pressing, obtundation, and status epilepticus, the actual molecular pathogenesis remains a subject of intense study and some debate.
It is fascinating how our understanding has evolved. For the longest time, we viewed ammonia as the sole villain in this story. While ammonia is undeniably central, the literature, particularly the state-of-the-art reviews by Lidbury and colleagues, emphasizes that it is a multifactorial process. Can you walk us through the current understanding of ammonia metabolism and why it remains the primary focus of our diagnostic and therapeutic efforts?
Absolutely. Ammonia is primarily generated in the gastrointestinal tract, not just through the action of urease-producing bacteria breaking down urea, but also through the metabolic activity of the enterocytes themselves as they catabolize glutamine. In a healthy animal, this ammonia enters the portal circulation and is detoxified by the liver via the urea cycle in periportal hepatocytes, or converted to glutamine by paravenous hepatocytes. When we have a portosystemic shunt, this ammonia-rich blood bypasses the liver entirely. The resulting hyperammonemia allows ammonia, which is highly lipophilic, to cross the blood-brain barrier freely. Once inside the brain, the burden of detoxification falls on the astrocytes. They utilize the enzyme glutamine synthetase to convert ammonia and glutamate into glutamine. The prevailing theory for decades has been that glutamine acts as an osmolyte, drawing water into the astrocytes and leading to the characteristic swelling we see histologically as Alzheimer type 2 astrocytosis. However, more recent data suggests that ammonia itself also drives oxidative stress, produces reactive oxygen and nitrogen species, and directly alters cerebral neurotransmission.
And that neurotransmission aspect is where things get even more complicated, right? We often hear about the gamma-aminobutyric acid system and the role of endogenous benzodiazepines. What does the evidence actually say about these inhibitory pathways in our canine and feline patients?
It is a controversial area. For years, the hypothesis was that increased inhibitory tone was due to a buildup of endogenous benzodiazepine-like substances. This led to the experimental use of flumazenil, a benzodiazepine receptor antagonist. While some comatose human patients show a transient improvement with flumazenil, the veterinary literature, specifically studies using dogs with surgically created shunts, has shown a poor response. This suggests that the increased inhibitory tone might instead be driven by neurosteroids. These are steroid hormones synthesized within the brain, often from cholesterol, and their production is regulated by the peripheral-type benzodiazepine receptor. In the state of hepatic failure, substances like ammonia and manganese accumulate and appear to upregulate these receptors, leading to an accumulation of neurosteroids that act as potent allosteric modulators of the gamma-aminobutyric acid A receptors. This effectively shifts the cortical circuitry toward greater inhibition, explaining the mental depression we see in chronic cases. Interestingly, manganese also plays a role as a direct neurotoxin, accumulating in the basal ganglia and potentially synergizing with ammonia to exacerbate astrocyte dysfunction.
It seems like a delicate balance because while we see this profound inhibition in chronic cases, we also face the catastrophic risk of seizures, particularly after we surgically attenuate these shunts. Before we discuss the surgical complications, we should touch on the diagnostic challenges. We know that fasting ammonia levels are a routine part of our workup, but they are notoriously poor at predicting the clinical severity of the encephalopathy. Why is that?
You have hit on a major frustration for many clinicians. A dog can have a blood ammonia concentration within the reference interval and still be profoundly encephalopathic. This is likely because the clinical state is influenced by all those other factors we mentioned: inflammation, oxidative stress, and the permeability of the blood-brain barrier. In humans, there is a strong emphasis on what is called minimal or covert hepatic encephalopathy. This is defined as a state where the patient has a normal mental and neurological status upon standard clinical examination but shows measurable cognitive defects on psychometric or neurophysiological tests. In human medicine, as detailed in the consensus statements from the Indian National Association for Study of the Liver, they use paper and pencil tests or computer-based tasks to find these subtle deficits. These patients are at a higher risk for developing overt encephalopathy and have a higher mortality rate. In veterinary medicine, we obviously cannot ask a dog to perform a number connection test or a digit symbol test. This has left a significant gap in our ability to identify patients who are neurologically unstable before they ever reach the operating table.
Which brings us to the importance of the surgical intervention itself. The literature, including the systematic reviews by Serrano and colleagues, suggests that surgical or interventional attenuation is generally superior to medical management for long-term survival. But the choice of technique, whether it is acute suture ligation, amyloid ring constrictors, or thin film banding, does not have a clear, evidence-based winner for every case. What are the key takeaways from the meta-analyses regarding these techniques?
The systematic reviews show that while surgical intervention provides a better quality of life than medical management alone, the evidence quality for one specific surgical technique over another is actually quite low. Most of our data come from retrospective case series. Generally speaking, amyloid ring constrictors appear to have a higher rate of complete shunt closure compared to thin film banding, particularly in extrahepatic shunts. However, thin film banding often shows excellent perioperative survival rates. The logic behind these gradual occlusion methods is to allow the intrahepatic portal vasculature, which is often hypoplastic, time to adapt to the increased blood flow and avoid fatal portal hypertension. But even with these gradual methods, we still see a significant incidence of post-attenuation neurological signs.
And that is the complication that keeps every surgeon and neurologist awake at night. Post-attenuation neurological signs, particularly generalized seizures, are reported in up to 12% of dogs and can be even more frequent in cats. Strickland's research in 2018 identified age and the presence of preoperative encephalopathy as independent risk factors. Can you explain why an older dog might be at higher risk for these neurological disasters?
The working theory is that the central nervous system of these animals has spent years adapting to a neurotoxic environment. When we suddenly change that environment by attenuating the shunt, we may be inducing a sudden shift in the balance of neurotransmitters. Some speculate it is a withdrawal syndrome from endogenous benzodiazepines or neurosteroids, while others suggest it is related to a sudden increase in cerebral metabolism that the compromised brain cannot handle. The older the dog, the longer it has been exposed to these alterations, and perhaps the more irreversible the astrocyte damage has become. This is why many of us now advocate for stabilizing the clinical signs of encephalopathy as much as possible before surgery and not delaying intervention unnecessarily.
We have talked about the background, the metabolic complexities, and the surgical risks. Now, let's pivot to the primary article we wanted to discuss today, which was published by Dupanloup and colleagues in the Journal of Veterinary Internal Medicine. This study specifically looked at the perioperative assessment of electroencephalography in dogs with congenital portosystemic shunts. This seems to be the first major attempt to define covert encephalopathy in our canine patients using neurophysiology. Can you walk us through their methodology?
This was a very well-designed prospective cohort study. They looked at 28 client-owned dogs that had a confirmed diagnosis of a single congenital portosystemic shunt. Crucially, all of these dogs had to have a normal neurological examination and no overt signs of encephalopathy at the time they were enrolled. They used ambulatory electroencephalography to monitor these dogs for 12 to 24 hours before the shunt was attenuated, and then continued the monitoring for 24 to 72 hours after surgery. They utilized 12 subdermal wire electrodes and captured time-locked video to correlate the electrical activity with the dog's actual behaviors, such as wakefulness or sleep. They didn't just look at the raw data visually, they also performed a quantitative analysis, looking at the mean dominant frequency and the relative power of different frequency bands like delta, theta, alpha, and beta.
It is a significant leap forward to use quantitative analysis rather than just relying on a clinician's subjective interpretation of a waveform. In the context of this study, how did they define a normal versus an abnormal electroencephalogram for these dogs?
They were very specific. A normal recording had to show no epileptiform or encephalopathic features and had to have a preserved sleep-wake architecture. This means they needed to see periods of arousal with high frequency, low amplitude activity, and clear non-rapid eye movement sleep transients, such as sleep spindles, K-complexes, and vertex sharp waves. An abnormal recording, which they used to define covered encephalopathy, was one that showed things like spikes, spike waves, polyspikes, rhythmic or periodic discharges, or a loss of those normal sleep transients. They also looked for diffuse slowing of the background rhythm. Essentially, they were looking for electrical evidence of brain dysfunction in dogs that appeared clinically perfect to the naked eye.
And the results were quite striking. Out of those 28 dogs that all appeared clinically normal, 4 of them actually had abnormal preoperative electroencephalograms. What happened to those 4 dogs compared to the 24 with normal recordings?
The correlation was powerful. All 24 dogs with a normal pre-attenuation electroencephalogram survived to discharge without any early-onset post-attenuation seizures. However, of the 4 dogs with covert abnormalities on their initial recording, 2 developed early-onset seizures, and 3 of them, that is 75%, died or were euthanized before discharge due to worsening neurological signs or surgical complications. This is a massive finding because it suggests that the electroencephalogram is capturing a state of neurological vulnerability that our standard physical exam and even our blood biomarkers are missing.
I was particularly interested in the quantitative findings regarding the mean dominant frequency. The study noted a significant decline in this frequency from the pre-attenuation to the post-attenuation period, especially in the dogs that had a poor outcome. Can you explain the significance of that spectral shift?
In the world of electroencephalography, background slowing is a hallmark of metabolic encephalopathy. The mean dominant frequency essentially tells us the average speed of the electrical activity in the cortex. In these dogs with poor outcomes, they saw a shift where the power of the high-frequency beta activity decreased and the power of the low-frequency delta and theta activity increased. This slowing of the brain's electrical signature often preceded the actual clinical onset of seizures or obtundation by at least 24 hours. It tells us that the brain is failing on a functional level long before it fails on a behavioral level. Interestingly, they also found a moderate correlation between the age of the patient and the mean dominant frequency, which ties back to what we discussed earlier about older dogs being at higher risk.
What I find most telling is that they found no correlation between the serum ammonia concentrations and the mean dominant frequency or the presence of these covert abnormalities. This really reinforces the idea that we cannot rely on ammonia as a surrogate for brain health.
Exactly. Ammonia is just one piece of a much larger puzzle. The study actually showed that most of the dogs had elevated ammonia, whether they had covert encephalopathy or not. This study points toward the electroencephalogram as a much more sensitive biomarker for the actual target organ of the disease, which is the cerebral cortex. The presence of epileptiform features like spikes and the loss of those normal sleep transients like sleep spindles and K-complexes are indicative of a highly unstable cortical environment. If we know a dog has these features before surgery, it might completely change how we manage them. Perhaps we would use more aggressive preoperative anticonvulsant protocols, or even delay surgery until we can further stabilize that electrical activity.
The study also provided some histopathological data for one of the dogs that developed post-attenuation seizures. It confirmed exactly what we suspected from the metabolic background cerebral edema and Alzheimer type 2 astrocytes. It is rare to get such a direct line from clinical neurophysiology to histopathology in a prospective study.
It really brings the whole story full circle. We have the biochemical bypass causing hyperammonemia and neurosteroid accumulation, which we can now see manifest as covert slowing and paroxysmal discharges on an electroencephalogram, which then correlates to the physical swelling of astrocytes, and ultimately the catastrophic clinical failure we see as post-attenuation seizures. This study by Dupan-Liu and colleagues provides us with a potential new standard for screening these high-risk patients. While ambulatory monitoring for 24 hours is a significant undertaking, the prognostic value it provides for a life-threatening complication is hard to ignore.
It definitely gives us a lot to think about in our clinical decision-making. As we wrap up this discussion, it's clear that while the liver is the source of the problem, the brain is where the battle is won or lost. Understanding these neurophysiological signals is going to be key to improving our surgical outcomes.
I couldn't agree more. This research moves us away from clinical guesswork and toward a more objective, data-driven approach to neurometabolic stability.
Thank you for listening. The titles for the reference papers are in the video description. From Vet Med Digest, where we keep minds inspired, hearts light, and tails wagging.